Well, welcome everyone, and thank you for joining us today for the first inHEART webinar of 2025 to discuss cardioneural ablation, case studies, and best practices. We've had over 150 people register for today's event, so clearly an exciting topic. We're joined by esteemed presenters, Dr. Mouhannad Sadek, electrophysiologist from Southlake Hospital in Toronto. And shortly, we'll be joined by Dr. Josselin Duchateau, clinical electrophysiologist at the Bordeaux University Hospital in France. Our guests will be sharing case studies and reports highlighting their use of the inHEART platform to guide cardioneural ablations. In addition, we are joined by guest panelists, Dr. Juan Zerpa, Director of Cardiosync Arrhythmia Center at the Hospital do Coração in Sao Paulo, and Dr. Tolga Aksu, Professor of Cardiology at AIU Medical Park, Florya Hospital in Istanbul. My name is Katie Arnold, and I will be moderating today's conversation along with my colleague, Kristen Lomas. We will be recording today's discussion for use online and to share with clinicians. So your continued attendance on this call will serve as consent to the audio and video recording and its distribution. Our format for today will include 2 case study presentations, followed by a Q&A. Attendees, we encourage you to submit questions throughout the presentation via the QA feature at the bottom of your screen, and we will work to incorporate your questions into the conversation. We have great cases to cover, so without further ado, let's get started. Dr. Sadek, we'll start with your presentation. Thank you.
Thank you very much for having me. I would like to thank the inHEART team for organizing this, and Dr. Zerpa and Dr. Aksu for moderating. Let me share my slides. So my name is Mouhannad Sadek. I'm from Ontario, Canada, and I would like to. I have nothing to disclose, and I will start with a case that was one of our more interesting cases. So this is a 29-year-old woman with recurrent syncopal episodes. She has a past medical history of Raynaud's, and her syncope tends to occur with pain or after exertion. So she gets the symptoms. She can usually sit down quickly and avoid falling. However, she's had multiple traumatic episodes. And even though she's able to now rescue herself and prevent the falls, this is still interfering significantly with her quality of life as she's unable to exert herself or exercise like she would like. So we did a treadmill test for her to see exactly what's happening after exercise. And she was able to, this is her maximal exertion, she was able to achieve 86, 87% of her target heart rate and was doing well with no symptoms. We then started the recovery period and got her to lie down on the stretcher. And about 30 seconds into it, she started feeling her symptoms come up, and she, let us know. And she developed slowing of the heart rate and then a long pause, a combination of AV block and P wave slowing, sinus slowing. And this went on for a second screen, a third screen, a fourth screen, a fifth screen, and a sixth screen. And actually, I wasn't there at the time, but a code blue was called. And of course, she woke up before anything happened, and slowly she got back her sinus rate. But for the period, she was syncopal. So a very profound pause and syncope, and we discussed with her, what are the options? Option number one is do nothing, live with it. There's significant warnings so she can avoid trauma, but clearly this interferes with her quality of life and being able to exercise or exert herself. Pacemaker implantation, something like a Medtronic device with a rate drop response, potentially prevent syncope, or cardioneural ablation. And we discussed all these options with her in detail. And the question is, do pacemakers help in these situations? There was the ISSUE 3 trial performed in Canada years ago, which randomized patients with recurrent vasovagal syncope and pauses recorded on Holter monitoring or loop monitoring to pacemakers that were left as a backup but turned off, um, or, or pacemakers and randomized to that, or pacemakers with rate drop response. So rate drop response is a Medtronic algorithm where if there's a drop in the rate, the pacemaker will pace at a faster rate to prevent the syncopal episode. And this study, it's a really interesting study because it's a true sham control study. It showed that the pacemakers do in fact reduce the rates of syncope, and they do work, but 25% of patients, despite getting a pacemaker, continue to have syncopal episodes. So they reduce but don't eliminate. In addition to that, we all know the complications regarding having long-term pacemakers, especially in younger people. You can have venous occlusions. Pacemakers can interact with the tricuspid valve, leading to tricuspid valve issues. The leads do not last forever, um, and will have to be replaced at some point, especially in a young patient. And you can have issues with device infections. And as a person who does device extractions, especially in leads that have been in there for a long time, it's not a benign risk to remove these leads if they get infected. So it's not ideal in a 29-year-old woman. However, there is the risk-benefit ratio, and of course, we don't want patients to continue to have syncopal episodes. There is another option, luckily, and it's cardioneural ablation, and this field has been growing over the last couple of years. And we know that there is ganglionic innervation of the heart, and we can identify the ganglia by the location of the fat pads, whether it be by pacing modalities or imaging modalities. And if we set our filters on our Bruca system to 100 to 500 hertz or 200 to 500 hertz, and we look for fractionation in the endocardial fractionation, we're able to identify the location of these ganglia. And this is a slide from Dr. Tolga Aksu. When there is homogeneous conduction between myocytes, we see normal signals without significant fractionation. However, when there is incursion of nervous fibers into the myocardium, this can lead to non-homogeneous conduction and presence of fractionation on intracardiac AGMs, which can be detected by our catheters. And that's really our main technique for identifying location of neuroinnervation. And when we started our program, Dr. Aksu kind of led us through this, and we really based what we do on his experience, where he showed that compared to conservative therapy, cardioneural ablation does reduce risk of vasovagal syncope based on EGM targeting. It's very important to really understand the location of the ganglionic plexi and have uniform nomenclature. So this is a diagram from statement published in the EHRA document. And the reference is down there. But I kind of think of the ganglionic plexi as septal GPs and non-septal GPs. And the septal GPs include the right superior or right anterior GP. You'll see both nomenclature. The right inferior or right posterior GP. Again, they may be called either. And the posterior medial left GP. And when you look at where these are located, they really are located between the left and the right atrium at the septal areas. So the right superior GP is in front of the right superior pulmonary veins. Below that is the right inferior GP. And if we go down even lower, next to the coronary sinus or behind the coronary sinus is the posterior medial left GP. And these are all between the left and right anglia. They can be accessed from the left and right atria. And here's a nice, on the bottom right corner, there's a nice image that shows the left atrium semi-clear and the right atrium here. And you can see how all three of them sit between both atrias, as opposed to non-septal GPs, which lay more on the left side, away from the right atrium. And you have the left superior GP up here, the left inferior or posterolateral GP, which is closer down below the left pulmonary vein, closer to the coronary sinus, and the mitral tract GP, which is more anterior between the left atrial appendage and the left pulmonary veins. I will start with, our usual technique and how we commence these cases. So we use ice for all of our left atrial ablations. We're lucky to have that in our center. And usually we were able to take pictures of the left atrium and formulate the anatomy of the left atrium. So we get a full anatomical picture of the left atrium. We also use the same ice during the same procedure to really draw all the valves, the mitral valve, the coronary cusps, the left atrial appendage, and the osses of the veins to really try to get a good anatomical view of the atrium. And the reason we're very detailed with this, and it takes about 10 to 15 minutes, is to able to merge with the cardiac CT scan we use to visualize the ganglia. So all our patients get a CT scan before it's sent to the inHEART team, where they process it based on post-imaging processing based on the fat pad location and the signal density, and they're able to label the ganglia for us. This CT scan is imported into the Carto system and merged based on the ultrasound data that we're able to calculate here. We do place a multi-electrode catheter, either a pentaray or an octaray in the left atrium. And we label all fractionated electrograms, and I'll show you examples while we're doing a voltage map of the atrium. And once the voltage map is formed, we use a combination of this voltage map and the ice map that we just made to merge it with the inHEART CT. And here you see an anatomical merge with a CT scan where you see the coronary arteries, the aorta, the esophagus here. I'm pointing to it behind the left atrium. The right atrium and the left atrium are also visible, and these here in pink or purple are the fat pads and the ganglia labeled by the inHEART team. We're able to import those directly into the system. And we have our fractionated EGMs also labeled, and we use a combination of the imaging that we have, the ganglionic plexi, and the voltage, and the fractionated EGMs to decide where to ablate. And here's an example of the merge where we've taken out the other structures to show what the final map kind of looks like before we start the ablation procedure. And this setup of the merging and taking the ice images and the voltage map usually takes about 20 to 25 minutes. So there's a bit of a time to set up the case before we start the ablation procedure. This is the typical images that you get. So here you have the right superior GP, the right inferior GP, and down here between the two atria next to the coronary sinus, you have the posteromedial GP. So these are all the septal GPs. And with respect to the left-sided GPs of the septum, there's considerable variety. Here's the left superior GP, and this is a nice image to show how the merge looks. I will also point out that there's also other structures that we need to be cognizant of. The phrenic nerve is also labeled on the CT scan in green over here. And it's very important because it abuts the septum right next to the right inferior GP. So, burn ablation in this area theoretically could cause phrenic nerve palsy, which is a complication of AFib ablation, where we also tend to burn in this area. So it's very important to be cognizant of it, and we tend to pace for phrenic nerve when we ablate in this area to make sure that there's no capture. In addition to that, the sinus node artery, which also can be location, which can also be imported from the cardiac CT, has a variable course, but could also run in this area as well. So it's important to be cognizant of that as well. And here are some examples of the signals that we can see. So in the area of the right superior pulmonary vein, or where the RS GPs tend to sit, you see these fractionated AGMs, and we don't really look at the amplitude. We look mostly at the number of deflections and fractionation. So 3 or more deflections, we tend to tag all these spots. And here's a typical example. So we tag all these areas, and one thing to note is most of these patients are young and healthy patients without significant scarring. That's also why we do a voltage map to assess the overall voltage of the atrium to make sure it's a healthy atrium. Patients with structural heart disease, for example, hypertrophic cardiomyopathy or other structural heart disease, they may have atrial scarring for that reason. And of course, in those cases, the specificity of identifying fractionated AGMs becomes less so because they may not correspond to neural insertions, but to simply slow conduction and scar tissue. So not only seeing if they have structural heart disease at baseline, but also knowing the typical locations of the ganglia. If you identify fractionated AGMs in areas where ganglia are not typically located, then that's something to be concerned about, and maybe we should not be ablating in these areas. And here's a nice example of an RSGP location with fractionated ganglia, or with fractionated AGMs over here. The RIGP as well. Nice examples of ganglia. Here's the LSGP. Again, you see very nice examples here, and the posterior medial left-sided GP. So all these are tagged using our multipolar catheters. Of course, sometimes, like I said, we see fractionated EGMs in areas where there is no anatomical correlation. So here's an example where you see fractionated EGMs in this area here without the presence of ganglia on CT scan. And of course, you have to decide what you want to do with these areas. We tend to not ablate these areas and really focus on the anatomical location of the fat pads in addition to the fractionated EGMs in these areas. And once we decide to ablate, it's about 25 to 30 lesions for us. And we tend to ablate all these areas of fractionated AGMs corresponding to the ganglia. If there are areas with typical ganglia, but we don't see typical ganglia locations, but we don't see fractionated AGMs, we also ablate the same areas based on CT because we're very happy with the merge that we make, that it's anatomically accurate. One thing to discuss is our ablation settings. So we've published our experience with AFib ablation in the past, showing that high power, short duration lesions, for example, 50 watts for 5 to 10 seconds around the pulmonary veins, give us shallow lesions, which are likely to give reduced complication rates, but able to isolate the pulmonary veins. And here you see an example of 50-watt lesions at 5 seconds and 10 seconds. They're quite shallow lesions, but sufficient for the purpose of atrial fibrillation ablation. Whereas for the purpose of cardioneural ablation, our thinking is that we want to be able to affect epicardial structures or deep septal structures. And for that reason, we want deeper lesions. So in order to obtain deeper lesions, we usually use lower watts for longer duration. And you're able to obtain deeper lesions, similar to applying lesions for ventricular tachycardia, where you want deeper lesions. So we tend to use 30 to 35 watts for 30 seconds. If you stay at 30 watts, the chance of a steam pop is extremely low, and we're able to get deeper lesions. But of course, collateral damage here becomes more of an issue. So if you're on the esophagus, need to be taken care next to the sinus node artery or next to the phrenic nerve. These are all issues that we have to keep in mind. We've been collecting our data. We don't have a huge data set, but we have been collecting our data with respect to the presence of ganglionic plexus on CT scan in the typical locations, whether we have fractionated EGMs, do we get a vagal response, do we have an increase in heart rate, and whether we ablate it or not. One thing I did not mention before is if we do get a vagal response, so heart block while we're ablating, we tend to apply more there until we lose the vagal response to make sure that we've achieved complete elimination. Our experience thus far shows that for the septal GPs, the CT scans tend to show them in all patients that we've done, but the fractionation EGMs are not typically always there. 80-90% of the time they're there, so we still ablate based on location, even if we don't see fractionated EGMs in those areas, if we're happy with the CT scan quality. For the left-sided GPs, we haven't always been able to identify them on CT scan, and same thing with fractionated EGMs. There are some cases where we're able to identify the posterior medial GP at the Marshall tract, at the Marshall tract GP next to the left veins and the left atrial appendage with fractionated EGMs, but we don't see anything on the CT scan. And we have actually ablated that because of the typical location there and have found a vagal response in some patients. So The correlation is not 100% perfect. We tend to ablate mainly based on anatomy, but also if we see fracture AGMs in the Marshall tract area, we tend to ablate there as well. There's a lot of questions to be answered in this field. You know, do we ablate all the ganglia, or do we stick to the septal ganglia only? And you'll see that our approach differs from my co-presenter, Dr. Duchateau. And you know, we don't know what the answer is, but we tend to ablate all ganglia, but some centers ablate only the septal ganglia with good results. Do we target anatomical areas in the absence of fracturing AGMs? We have been doing so, but you know, that's a question to be answered for the future. What is the ablation endpoints? Our center's ablation endpoints is to eliminate all the anatomic and AGM areas, and if we achieve a vagal response, to continue to ablate until we lose the vagal response. Some centers perform high-frequency stimulation, and they look for positive response to that or elimination of the response to that. Other centers use extracardiac vagal stimulation, which my co-presenter will be speaking about. And other centers use response to atropine. So these are things that different endpoints that different centers use. And of course, you know, should we be concerned with unforeseen risks? We talked about phrenic nerve and sinus node artery. We are forming scar in these patients, and they're young patients. Does this put them at risk of future atrial flutters, you know, 5-10 years from now? We have not seen that, but that's something to be, you know, concerned about. And long-term recurrence, you know, do the ganglia re-innervate? Is there a healing process? And is this something that we have to repeat in 5 years, etc.? And of course, you know, a lot of these episodes tend to be time limited. You know, these patients, if they're 29, 22 years old, they may not continue to have vagal syncope their whole lives. And maybe we just need to treat this time period. So long-term data is also needed as well. Thank you very much for having me give this talk.
Fantastic. Thank you so much, Dr. Sadek. I'd like to open up the discussion to the panelists. We will also take questions from the audience, but I'd like to open it up first to the panelists if they have any questions.
I would like to start. Actually, thank you so much. Great for this great presentation. I think that still we have two important questions about cardioneural ablation strategy. The first one is the best GP mapping method, because we still don't know the best technique. But I think that the other important question is related to procedural endpoint. And I think that if we can find the best GP mapping method, then we can find the best procedural endpoint. You know, in AFib ablation, for example, we know that we should demonstrate intrinsic and extrinsic block. This is a very good endpoint. But cardioneural ablation strategy, we still don't know the best technique, because, you know, maybe Juan can say me, because he used extracardiac vagal stimulation for too many years, and he have too many experience about that. But I think that extracardiac vagal stimulation has some limitations. For example, by just performing right atrium ablation, we can achieve negative extracardiac vagal stimulation response. But once we follow this patient long term, we are seeing reinnervation. So what do you think about that, Juan?
Yes, as a matter of fact, we are used to use extracardiac vagal stimulation for a long time, because it's like intracardiac echo. Once you start doing, you don't want to stop using that. Why is it? You can measure the effect of the innervation that you can achieve when, that's an example, when you ablate only on the right side and you have a good extracardiac vagal stimulation elimination of that response. That may be the endpoint, and that may be the time to stop. Is as a work that was published by Dr. Roman Petrovsky. He tried to compare on the right side before, on the left side before. Ablating on the right side, he had fewer elimination of this cardiac vagal stimulation. He always has, the most of the time, he has to go to the left atrium. When he started on the left atrium, he needed to go in fewer occasions to the right side. But it's a way to understand how much are you ablating, how much denervation you can achieve, and trying to find a higher level of denervation. Well, I personally think that it's impossible to achieve complete vagal denervation of the heart, but you have to aim for a high level denervation, thinking in reinnervation process and thinking in long-term follow-up. Mo, I have another question for that, because this tomography approach, this tomography integrated approach, put together anatomy, electrograms, and all that we are been doing all these years. Cardioneural ablation started with Dr. Pachon doing atrial fibrillation ablation. He understands the electrograms, describing compact electrograms and fibrillar myocardium. He called it atrial fibrillation nest. And these fractionated potentials has some correlation with CT, but it's not 100% that you already tested there. Do we need to ablate only in the correlation with EGMs and fat pads, or maybe find it only with EGMs, or tomography is going to change this? Because we have to aim, we have to pursue always to ablate less and to map more. What do you think about that, Mouhannad?
That's a great question. And, I'll be honest, I'm going to tell you what I think, but I don't know the correct answer. When we started our program based on Dr. Aksu's teaching, he did rounds with us, he showed us the way he did it, and we started doing it based on fractionated EGMs before we started doing CT scans. And we had good results. There was a clear endpoint, target all fractionated EGMs. And then when we started doing CT scans and looking at the location of the fat pads, there was some location areas where it's a typical location. So, for example, the right inferior or right posterior GP, you see a nice ganglia there, but we didn't see fractionation. And we would ablate there and see, some sinus node increase in the rate. So we've developed this technique of relying on both, but I would say EGM is very good by itself, fractionated EGMs, because we see, like I showed, like 80-90% of the time they correlate very well, just not 100% of the time. And seeing the ganglia on CT gives you a bit more confidence that there is something there, there's a fat pad there. But I think the EGM approach is excellent. It's very good. Not all centers have access to CT scans regularly, but I think having both gives us more confidence. So I think we mainly target EGMs. If there's a typical location of ganglia where we don't see an EGM, we still ablate there anyways, and we've had good response with this approach. And I have to say, it does give me more confidence when I do the merge and I see that there's fractionation in the area of an EGM. And like I said, the other thing can happen is you see fractionation in the area where it's not a typical location for an EGM, and these we tend to ignore. I don't know if Dr. Aksu does the same. If it's like on the middle of the posterior wall, we would not ablate there. The esophagus is there, we're increasing the risk, and it's not a typical location. So that tends to be our approach, looking at both anatomy and EGMs.
Yes,
Yeah,
Mohammed, this is great. Sorry, Josselin, please.
Yeah, I just wanted to comment on that. So I agree with everything that's been said. I have personally some issues with understanding the rationale of having fragmented signals in areas that should be targeted. I think everybody agrees that most of the GPs are epicardial structures, and the areas that they are actually innervating are remote. I mean, where the axons go are remote from where the cell bodies are. The axons are targeted towards the AV node, towards the sinoatrial node, and they're not really targeted towards the local muscle next to where these GPs are, actually. So this is why I have some issues with the concept of having these fragmented signals in the first place. So we had a study about this recently published that shows that there is some amount of co-localization between fragmented signals and where we see the fat pads. But from the way we looked at the data, so this is very close to what Mo just said. I mean, when you look at the data more objectively, you have fragmented signals near the interventricular septum in areas where you find a lot of GPs, but you also have fragmented signals elsewhere. So it's not something that's very specific of an area that contains GPs. That's a real first issue. So this is why actually I take I take the problem the other way around. I really focus on the fat pads. I think that there is enough data in the literature to be confident about the fact that a large amount of the GPs are located next to the fat pads or in the fat pads. There's some significant co-localization. And I think it brings a lot of objectivity in the analysis. I mean, when Pachon started out, he did this fast Fourier transform of the signals to really identify the areas that were fragmented. This is something that's not available in routine. Counting the number of deflections with a different bandpass filtering on your EGM system is also not something that is always very simple to do. And I find that having the information from the CT is something that at least once you've done a good merge is something you can rely on and has some amount of inter-observer reproducibility, which is what we also tried to show in our paper.
Okay.
I think that the way to go will be related to AFib ablation, because if we are talking about cardioneural ablation, we are doing this procedure in very young and healthy population. But the merging of CT will provide too many information during AFib ablation, because in AFib patient there will be fibrosis and it will also cause some fragmentation on electrogram. So cardioneural ablation patient population will give us an answer about which epicardial fat pad is more important for GP area, because you know that epicardial fat pad is very, very large area. And we know that GPs are not located throughout the whole epicardial fat pad, just localized in some part of this epicardial fat pad. And maybe in near future, we will define which area of epicardial fat pad contains more GP by changing some parameters, because to do that, we need to combine peak frequency or fragmentation on electrogram, and maybe we will be sure about that. If you see such a thickness on epicardial fat pad, it may be related more GP or it may contain more GP, and then we will have a chance to more focused ablation in near future. And of course, anatomical and reliable marker will be the best for that.
We have some questions for the audience as well. Maybe we can take some comments on this, Tolga. The first is from Verena Sol. She tells that heart rate variability is reduced after cardioneural ablation. We take this question a lot. What are you thinking about the prognostic factor if we reduce this heart rate variability?
Yeah, according to our experience, and you also can share your experience, but according to our experience, yes, we change heart rate variability. But as you mentioned at the beginning of the presentation, complete vagal denervation is not possible in human. This is the first. And the second one, we will see reinnervation in future. Because you know that after cardiac transplantation, we are seeing reinnervation in the new heart. So it's not possible complete or completely durable vagal denervation. So this is why we don't see any increase on sympathetic related ventricular arrhythmia or sudden cardiac death or something like that. And the second issue, the second important issue, during cardioneural ablation, we are also causing some sympathetic denervation. According to our heart rate variability parameters, we also see a decrease on sympathetic parameters as well. So this is why we don't see any arrhythmia related to sympathetic overactivity. This is my point.
And this is a different kind of patient because he have no ischemic cardiomyopathy or heart failure. And in these patients, you have a high level of vagal denervation, but you don't free the sympathetic tone is still the same. And it maybe has a low down regulation on that. We have not seen pro-arrhythmic effect. We have not seen increase of sudden cardiac death or heart complications as well. So this is something that we have to follow really, really close to find if you have side effects or adverse effects in these patients after ablation. And let me see, we have two more over here. Is Dr. Felipe Hortensio just asked it. He congratulates Dr. Sadek for the presentation. And should we follow local mapping of the electrograms or proceed with anatomical ablation based in the landmarks and based in the GP locations? One thing that I'm going to put over there too is we map in the endocardium and the fat pads are on the outside. So that's why maybe we don't have this complete correlation. It's like the central computer is outside and you have this complex network of interconnections in the atrium going to the sinus node and to the AV node. Or should we ablate by guided on the electrograms of the anatomic landmarks only, or maybe mix it?
I think, this is the question we've been talking about the last couple of minutes, and I think I wish we knew the answer. We have been, looking at both, and mainly anatomy, but really both. But I think that question remains to be answered, and everything you guys have said is but the other question is, do we need to ablate all GPs? Because in discussion with Dr. Duchateau, I tend to target all GPs, including the left-sided ones off the septum, whereas some centers will only target the septal GPs. So we have so many questions about what's the right thing to do is. We've had good experience with our patients. And there's been good experience from Dr. Duchateau's patients in the paper as well. So it's just finding, we're able to help our patients, just finding the right amount of ablation. Are we over ablating? Are we under ablating? And which technique will give you the longer success rate and follow-up. So yeah, it's an exciting field. I don't know all the answers.
I think in interest of time, we'd like to move forward with Dr. Duchateau's presentation. I know we have a couple more audience questions we'd like to get to at the end, but Dr. Duchateau, if you're ready to get started, that would be fantastic.
Yeah, if you can give me 2 seconds.
Sure.
Hold on.
These 2 seconds, keep the questions coming. We're going to have much time to discuss this at the end.
But what's your opinions, Dr. Aksu and Zerpa, regarding, as Dr. Duchateau? Oh, there you go. It's open.
I think we can mix everything. We can mix mapping, we can mix anatomy, landmarks. The more information we have, the more selective are we going to be with ablation. And maybe focusing ablation on these sites that are correlated, that you have the higher response. And on my side, I always defend extracardiac vagal stimulation, because if you can ablate less and abolish this response, you're going to have a good result in the long term.
Can everybody see my page?
Yes.
Okay, great. So I'm just gonna, I wish I was in full screen. Full screen, but it's okay. So I'm just gonna talk about this case to illustrate some of the points I want to make. I think a lot of what I'm going to say has already been said, so I'm going to try and repeat and focus on the things that are a little bit different from the approaches that have been described. So this is a 31-year-old male who's a sailor. So for him, in terms of his professional activity, having syncope is, of course, a big issue. And he's had multiple recurrent syncopal episodes with short prodromes. And so we started by performing a standard cardiology routine, like exams with an echo, with ultrasound. So there was no sign of structural cardiomyopathy, no cardiac pathology that could be detected. And we performed a tilt table testing where you had a mixed response with only a short pause of 5 seconds after nitrates were given. This is a patient that had no sleep apnea. And we eventually decided to implant an ILR to have a certain diagnosis. And you can see that after a while, he actually had a recurrent syncope. and had these tracings on his revealed link device, so with a very long pause. And you can see that there's only minimal slowing of the sinus rate before the pause. And actually this patient, I think this probably explains why he has minimal prodromes. He has almost a very abrupt sort of asystolic event with complete sinus node dysfunction at that time. So this allows me to stress on one thing, the way that we do patient selection. This is something that's a little bit different from the procedure itself, but I think it's very important, especially since most of the published cohorts about cardioneural ablation have focused on selecting patients based on tilt table test results. And you saw that in this patient, we had like a mixed response at his tilt table testing. But in fact, you have this study, so the reference is not right, but this is a study by Duchateau, I think it's a JACC paper in 2004, something like that, that shows that there's a very weak correlation between the tilt table test response that you get in these patients and actually the spontaneous events that they have as defined by ILR recordings. So actually there's no correlation between these two types of events. So you should not base your patient selection on tilt table test results. You have patients that have negative tilt table tests that actually end up having huge pauses when you put in an ILR, and the other way around. So you have some patients that really have pauses when you perform tilt table testing, but actually they never have spontaneous asystolic events. And I think they're probably not good candidates for cardioneural ablation. And this sort of concept is backed up by the fact that tilt table testing doesn't predict cardioneural ablation response. This has been well documented in the biggest cohorts of patient that was published about cardioneural ablation, where you see that the results of tilt table testing was independent from the phenotype that was observed. The result of cardioneural ablation was independent from the phenotype. So I think you should use ILRs for patient selection in one word. And I think it's also very important to have ILRs for follow-up because it's a procedure we don't know much about yet. So this has already been said. I use a different sort of naming convention that was based on the work by Armour, which is one of the oldest studies about the anatomy of the GPs. So I just wanted to comment on that. And you'll see that this matches very well with the anatomical findings that we have on CT. So basically, the two targets for cardioneural ablation without going into the naming conventions are this fat pad here that's located at the posterior interatrial groove, so next to the right pulmonary veins here. This contains actually the most important number of cell bodies, neuronal cell bodies, that you can find when you do a histology study. So this is really where you have most of the neurons. And the area where you have the second most amount of neurons is what Armour calls the left posterior medial GP, which is located here near the ostium of the coronary sinus, also in contact with the posterior interatrial groove here. Okay, so these two areas are the ones that I target because I want to focus on these neuronal cell bodies, and this is where they're mostly found, okay? So Tolga mentioned that not all fat contains neurons. This is absolutely true. I mean, these are the fat pads that have been described by Armour, and there's also significant amounts of fat that are located, for example, in the AV groove, and you see that in these regions you have much fewer neurons, and I think these areas do not need to be targeted in a mandatory fashion. Possibly you should target them if you have failed ablation on these more classical sites, but our approach is to target these areas first. Okay, so we have a moderate, sort of incomplete understanding of the functional innervation, but the data is progressively accumulating, and I'm trying to summarize it here in this schematic. Basically, we know that the posterior GP the posterior right GP here, so this area here, mostly innervates the sinoatrial node and also partially innervates the AV node. So if you want to target the sinoatrial node and you ablate here, this is your best bet for obtaining the denervation of the sinoatrial node. And the left posterior medial area here is where most of the innervation towards the AV node takes place. So these are the two regions that we target more specifically. Okay, here I want to highlight something that I'll be coming back on, but you see that even if you want to denervate the AV node and you're ablating in this region, you might get AV node denervation, not because you're damaging the neuronal cell bodies, but because you're damaging the axons that are coming down through this region here. So by ablating the posterior interatrial groove here, you can denervate the AV node, but it won't last long. It'll only last for a few months because you've just killed the axons and not the cell bodies themselves. This is something that's very important. And there's a point here that's been described as the cardiac nexus by some authors that's mostly located in this area here. And if you ablate here, you'll get spectacular acceleration of the sinus node, and you'll have spectacular acute denervation. But my opinion is that probably this denervation will be very transient. And after a few months, you will get reinnervation because you've not damaged the cell bodies themselves. Okay, so this is what it looks like. And most shown you images like this when you look at a real patient. These are, you see the fat pads, and what you have with the different colors are different levels of erosion, meaning that you have some fat that is progressively removed, and the darker areas, the dark purple areas, correspond to areas that are more like spherical in terms of shape, so really correspond to fat pads rather than fat sheaths. Okay, let me just show you that again. Mo mentioned the phrenic nerve here, which is an important structure you have to avoid damaging. He also mentioned the esophagus that I'll be coming back to. But you see that you have a nice fit between this anatomical observation and what was described by Armour. This is very similar to the images that he shows. So our routine workup is to do a rapid mapping of the left and right atria. So this is not something that's very important for you to see, but basically we do an anatomical map of everything. We use also a multi-spline catheter because we want to have information about fragmentation that we collect and that we look at, even though we're not using it for our strategy anymore. And once you've done that, sorry, okay, go to the next page. Okay, once we've done that, we merge the CT scan that was collected before the procedure with the anatomy that was created using the catheters. So we try to get as precise a merge as possible because we're really going to use the CT data for the ablation. Okay, so we do that for left and right atrias that you can see here. And then we go on and we start by locating the phrenic nerve. So we do some high output pacing to make sure that the CT derived phrenic nerve is located properly. You can see here, for example, that there was a small bend that's not really there on the day of the ablation. So this is very important because we're going to be ablating close to the phrenic nerve. You can see we're going to be ablating around here. So especially in the area that we're going to be targeting, we want to make sure that we're safe and that we're not damaging the phrenic nerve. As Mo mentioned, we're also going to be doing lesions that are only maybe 30 watts, but that are lengthy. So probably a minute of ablation at 30 watts. That's because we want to target epicardial structures. So you have to keep that in mind, that these settings are also going to be more dangerous for the phrenic nerve because the phrenic nerve is also a deep structure. And it's not going to be as protected by these settings as it is when you're doing conventional PVI and high power short duration burns. So I think it's very important to keep that in mind. Then we do transjugular vagal stimulation. So this has been well described by Juan and by the Pachon group. So you go up to the superior molar tooth at this area. This is an interesting area because you have no sympathetic innervation at this level. You're purely vagal innervation. You can actually capture the vagal nerve pretty much anywhere or along the trajectory of the internal jugular vein, but being high up here allows you to be very selectively only vagal and allows for truncular capture, so non-selective capture of the vagus nerve. So it allows you to get both like sinus node slowing and AV block. So we start by doing that on the right side, and when you do that, you see that you get asystole. This asystole is due to sinus node arrest. But if you do that pacing from the CS at the same time, you see that you also have underlying AV block here. Okay, so it's a vagal effect that has an impact both on the sinus node and on the AV node. This is also an important point to show you. So here you have the different arteries. This is the aorta, and you can see that this artery here is the sinus node artery. In this patient, it was a branch of the circumflex artery, which is a variation of normal anatomy. Most of the time, the sinus node artery is a branch of the right coronary artery. But in this patient, it was a branch of the left circumflex artery. And what I want you to notice is that it goes through this fat pad here, which is just between the aorta and the superior vena cava. And ablating in this region, this septal region here, is an area that, in my opinion, is at risk of having a thrombosis, an ischemic thrombosis of the sinus node artery. So I tend to avoid this region and really focus on the posterior GP here. When you look at the different case reports of sinus node dysfunction after cardioneural ablation, what they all have in common is that the authors ablated in this region. And this is very clear from the different published case reports. So try to avoid this region as much as you can. So, so I want you to, so this is what we do. We start by ablating we start by denervating the sinus node. So you might notice, so this went a bit fast, but there was nothing really specific about the signal there when we started the ablation. And you can see, let me just come back, sorry, to the previous slide. Start the slide again. Okay, you can see that the patient starts out, it's not fragmented here, and the patient starts out at around with a heart rate below 60 beats per minute, and very rapidly, when we applied radio frequency there, he had a rapid acceleration of his sinus rate to more than 70 beats per minute after a single burn. So clearly, I mean, this area here was an area of interest in terms of innervation. We don't stop here. We ablate the entire fat pad because we know that we can get presynaptic damage to the axons that are coming down to this fat pad. And we could also potentially get postsynaptic axonal damage. So we do ablate the entire fat pad anatomically before moving on to the next area. Once we've done this ablation, we do vagal stimulation again. So this is the same region as before. And you can see that after just this series of burns, there's no longer any response to vagal stimulation. Okay, so it might appear that the patient is fully denervated, but as I mentioned, when you do this, you're ablating both the cell bodies that are going to the sinus node, but you're also ablating the axons that are coming down to the left posterior medial GP here that are going to be innervating eventually the AV node. Okay, so by ablating here, we damage these axons, and this explains why we no longer have a response when we're stimulating the right vagus nerve in terms of either sinus node dysfunction or AV block. And what we really need to check is that innervation of the AV node is still active, especially from the left side, so especially from the left vagus nerve, because these components don't go through the area that we've just damaged. Okay, okay, so I'm just going to skip this. So to do that, we go into the left internal jugular vein. So this can be a bit difficult to do. This is why you see there's the echo probe here. So we tend to get stuck on there's a valve at the junction between the left internal jugular vein and the innominate vein. So it's hard to cross sometimes. Sometimes we have to use a wire and a sheath, and sometimes we use echo guidance to go through. But once you're through, it's really straight up, and you can go and stimulate this region very easily. So when we do that, so you see that we do have a good denervation of the sinus node. We have a very little slowing of the sinus node, but we see that the AV node is not denervated because we've not targeted the neurons that are going there. So we do have some residual response there. So to do that, when you're ablating the AV node, you don't have the heart rate to focus on during ablation. So what we tend to do is to pace just before the Venkaback point to have a long PR and one-to-one response. And this is where it's most sensitive to see potential PR shortening, okay? What you notice on this live view is that you have a PR that's about 170 milliseconds here. And also you saw that there was some fluctuation in the PR interval. This fluctuation in the PR interval is timed with the breathing of the patient. So this patient is under GA, and you have fluctuations in PR that are timed with the breathing. And this is a sign of an intact vagal innervation. So this is a vagally mediated effect. So once we ablate here, you'll see, so hold on. So this is not during ablation. So I'll come back to that when we ablate. Before we ablate, just one thing to keep in mind, and this has been mentioned by Mo, I mean, you have to be careful about the esophagus. It's very close to where we're going to be ablating. And so we do that with a temperature probe as well to make sure it's not going up. If it goes up, like on the right side, that also means that you're not protected by fat. So most of the time, it means that you're not targeting the fat pads themselves. You're actually ablating next to a fat pad. So it's also an indirect marker that you're not on the right spot, okay? And so when you do that, you see that there is the fluctuation in the PR here. And when we start the ablation, you'll see two things. You'll see that the PR will stabilize. Okay, so now the ablation is ongoing. PR will stabilize, the fluctuation will stop, and it will slightly shorten. Okay, so this is what you're seeing now. The PR is slightly shortened, and you've lost all of the fluctuation that you had before that was due to vagal innervation. Okay. So having this sort of trigger view is a nice way of seeing that. It allows you to be quite precise in your measurements. Even the changes can be sometimes spectacular. You can win maybe 80 milliseconds, and sometimes they're very, very discrete. The PR might only change by 10 milliseconds or something like that. But you can always see that when you put this marker here and you have this triggered view. It's a nice way of seeing that. Okay, then we resume vagal stimulation. So you see that the effect that we had is only partial. So we had some denervation that we saw with the changes in the fluctuation, but I think it's very important to have this vagal stimulation because it's the most sensitive way of assessing the acute denervation effect. I agree that it doesn't predict necessarily long-term effects, but clearly it's something that is very valuable, at least for the acute results. So since we had an incomplete denervation, we really focused on the GP again, ablated some more. We also saw that there was some more shortening of the PR. You can see that the PR is even shorter than it used to be. The marker hasn't changed. And then we reassess by re-stimulating here, and we see that we're good. I mean, there's no longer any response to vagal stimulation, so we have a good acute endpoint. Okay, so these are my conclusions. So we need to target the GPs. I think that there's very strong arguments in the literature to say that these GPs are mostly located in the fat pads, and I think this is why it makes a lot of sense to use the CT to locate these fat pads and focus on these anatomical regions. I use transjugular vagal stimulation, just as Juan said. I mean, once you've started using, you cannot stop because it's so useful. It's a great tool to I mean, it opens up, in my opinion, it opens up a new field of evaluation in cardiology in general. I use it for a bunch of other procedures, for VTs, for lots of things. I think it's really useful tool. I think it's important to remember that there's right-left selectivity in the innervation. You saw it here in this example, that the left side tends to innervate the AV node more, and the right side, the sinoatrial node more. So there's some fluctuations between patients, but it's important to keep that in mind. And you should give special care to avoid complications, sinus node artery damage, phrenic nerve palsy, and esophageal lesions. Okay, thank you very much.
It was a great presentation, Josselin. We're still gonna convince Tolga to try it, and then we're gonna change the way he sees things, and maybe he join us on the CBS. I just want to make some comments about complications. It's something that everybody gets concerned about. What does DCT images give you as an information to avoid sinus node artery, phrenic nerve, and esophagus? Can you explain a little more about it? And
Yeah,
how
sure.
do you combine the anatomy of the CT with the mapping?
So, so for the esophagus, it tells you that the esophagus is next to the left posterior medial GP. Once you know that, you don't necessarily need a CT scan for every patient. You just need to keep in mind that this can be an issue, and that I would recommend using a temperature probe. So for this specific indication for the esophagus, it's not, in my opinion, mandatory to have a personalized CT scan for every patient, but it's very nice to see that there is very close proximity between the esophagus and the areas that we're targeting. So it's more of an educational point for this specific complication, in my opinion, than really something that makes a lot of sense clinically. The other interesting thing I feel is that this proximity and the usage of the thermal probe allows you to know whether or not you're ablating on fat or you're ablating right next to fat. And you can see that the kinetics of the increase in temperature are completely different. I mean, this is something that for those who are familiar with AF ablation using a temperature probe, sometimes you have points where you're really close to the esophagus and you ablate, and temperature barely goes up, very slowly, and then you just move like a few millimeters to the side, and then you have super rapid increases. And this is also what you have when you're ablating the left posterior medial GP. And if you have a super fast increase, that means you're not on the fat pad. It means you're directly on the muscle, and nothing's protecting the esophagus from your ablation. Okay, so it's also an indirect marker of whether or not you're on the right spot. So this is for the esophagus. For the sinus node, it shows you the trajectory of the sinus node. The trajectory of the sinus node is also somewhat reproducible. It always goes through this superior, so this GP between the aorta and the SVC. So I don't ablate there anymore. I used to ablate there at the beginning of my experience. So maybe 3 or 4 years back, I used to ablate there. And then I got concerned because then at that time, there were some reports of sinus node dysfunction, and they all had in common that they were ablating there. And I found that I've tried doing sinus node ablation specifically for some indications, and it's actually not easy to do. So I sort of couldn't understand how these guys were getting sinus node dysfunction. And I thought it was quite likely that it was because of an ischemic effect and a damage of the sinus node artery. And this is also a hypothesis that was formulated in some of these reports. And so visualizing the sinus node artery and its trajectory is also very helpful, because you notice that it's always in this region, and therefore I just stopped ablating there altogether. So even if I don't see the sinus node artery, because on some CT scans it's too small to really have a good segmentation, I don't ablate this area between the aorta and the SVC as a first endpoint, as a first goal. I focus on the posterior GPs that are a little bit lower. So this is for the sinus node artery. And for the phrenic nerve, this is probably where it's most helpful, because there's a very wide interpatient variability as to where the phrenic nerve actually goes through. Sometimes it's really in the interatrial groove, and then it's very, very dangerous to ablate there. You have to be super careful, and I tend to use a setup that's similar to what we use for cryo. So meaning I pace the phrenic nerve continuously during the ablation to make sure that there's no loss in capture. I know that, for example, Philippe de Bruyn does everything under QRRs. I don't use QRRs because, I mean, then you cannot check for phrenic nerve palsy, and I think it's dangerous for cardioneural ablation. And sometimes the phrenic nerve is really, I mean, far, very anterior, so far from the area of interest, then you're not bothered at all. So the relationship between these GPs and the phrenic nerve is something that I find very useful from these segmentations.
Okay, have any comment?
Mo, what are your impressions? How do you use it?
Oh, sorry.
Do you, Juan, do you see any phrenic nerve problem in your maybe 1,000 case experience?
It's really, really rare. It's really rare. We don't go that posterior on the right atrium, and we don't go that inside of the right superior pulmonary vein that maybe you can have some passing of the phrenic nerve there. It's really, really rare that you have that. In some alterations and anatomy, sometimes you find it in the posterior wall of the right atrium. So maybe you have to be careful there with phrenic and sinus artery.
Yeah, Mouhannad, please.
Oh, I was just gonna say over the years, I mean, we've done thousands of AFib ablations. We've had 2 phrenic nerve palsies, and that's what makes me nervous about the phrenic nerve. Never seen it in CNA, but I've seen it with AFib ablation, with radio frequency. The days when we didn't do high power short duration, when we did long lesions, is when we saw it. So we're doing long lesions for this, which is why we're a bit careful. But no, I haven't seen it for CNA ablation.
And maybe something also that should be mentioned, you know, phrenic nerve palsy is something that's sometimes asymptomatic. So if you have a patient under GA with positive pressure for ventilation, and you're not checking for phrenic nerve palsy systematically, and you're not assessing phrenic nerve function, you might underestimate the rate of phrenic nerve palsy that you're actually getting. So this is why, at least I don't know what your position is for QRRs, because, for example, having QRRs makes a vagal stimulation much easier because you don't get the capture of the sternocleidomastoid muscle. So you get less peripheral muscular capture, but then you can't assess the phrenic nerve adequately, I think.
So if the phrenic nerve is going exactly where you want to ablate, Dr. Duchateau, you just don't ablate there, right? There's no choice for you in the map.
No, so actually it's never exactly where you want to ablate, because you have to keep in mind that the phrenic nerve is an extracardiac structure. It's behind the parietal sheath of the pericardium. So it's really on the other side, but it can be very close. So I tend to ablate there, but I do that under continuous pacing of the phrenic nerve to make sure that there's no loss of capture, no like a reduction in the diaphragmatic movement.
And I saw you're posterior to it as well when you're ablating most of the time.
Yeah, so you're posterior, as Juan mentioned. I mean, you need to be ablating sort of this junction at the interatrial junction. So most of the time you're slightly septal to where the phrenic nerve is. You can never really be on top of it because it's always more posterior to where you're ablating. The structures that we're targeting are slightly more septal, slightly less epicardial compared to the phrenic nerve.
Dr. Zerpa, if you want to pick 1 or 2 more
Yes,
questions.
I'm just speaking it over here.
From the audience.
We have some questions about the Cardioneural Ablation guided for the AV block, and we have Tolga here. I think that's why we have those questions, because can you concentrate your ablations only in one GP group, like for AV block, only in the posterior medial, in the inferior GPs, in septal GPs, and maybe sometimes including the left GPs? We have the experience, Josselin and I, we do extracardiac vagal stimulation on this, and we're going to make a comment after that. But what do you think, Tolga? Can we just concentrate on the AV node at the innervation, or is a mixed connection of the GPs?
Yeah, I think the most difficult patient population is AV block patient. I think the reason is to select good candidates, because it's not easy to say complete the functional AV block or whether there is any structural component of this AV block. So I think that the most important reason of failure is patient selection, I guess. In the second issue, I always try to do a step-by-step ablation in AV block patient. I always start from posterior medial left GP and then check the response. And then in the second station, I go to the Marshall tract area and also left superior GP, because once we ablate right superior GP side or right posterior GP side, we increase the sinus rate, and we usually cause a worsening on AV block status, because we increase the sinus rate and then the status of AV block usually worsen. So if there is nothing about the sinus node, I just try to focus AV node area without increasing the sinus rate. But of course, in almost 30% of patients, we achieve the desired target after ablation of right superior GP side.
And you are managing with measuring the cycle of Wenckebach on the point,
Yes.
just to see how do you improve.
Actually, in AV block patient, I usually perform electrophysiological study in another session, at least 24 hours ago, and I check the AV node Wenckebach point, IH interval, and other parameters before and after atropine administration. Because, you know, in some patients, there is just paroxysmal AV block, but maybe in 70% of patients, we are doing this procedure for persistent AV block, persistent mobility type 1, persistent first degree AV block, for example, 300 millisecond PR interval or something like that. So we already know post-atropine response on our procedural endpoint.
Yeah, Josselin, did you see some differences in AV node cardioneural ablation? Or do you stimulate only the left vagus, or you go for the right and then you change it to the left?
So I always check both sides, because I think it's very important to check both sides. I ablate only the left posterior medial GP, and I find I have good results with this. So at least acutely, and even so, maybe I don't have a lot of patients with long-term follow-up. I would say maybe half a dozen that were purely AV block, and they have very good long-term follow-up when you get very good acute results. I think it's important to check both sides, typically because innervation of the AV node comes from both sides, and because sometimes you can also get good acute results from the left side, and then you still have some response when you're stimulating from the right side, and this points to the fact that probably you haven't denervated enough the right portion of the left posterior medial GP. So I find where there's residual, so which side has residual activity, also useful to imagine where I should extend my lesions, in what direction. Okay, so let's say I've just done some ablation and I have residual activity on the left side, then I tend to extend my ablations towards the coronary sinus, towards the left side. And if there's residual activity on the right side, I tend to extend the ablation towards the interatrial groove, going up the interatrial groove. Okay, and I use the same as you. I think the extravagal stimulation is the best endpoint. And I agree with Tolga. I think probably patient selection is key. And that for me, patient selection goes through atropine testing, because if the patient gets a normal conduction after atropine testing, you have a very strong case for saying that at least part of his problem is due to a functional issue, to extracardiac issue. Okay, it doesn't mean it's 100% functional and 0% structural, but it means that at least with cardioneural ablation, you'll be able to have some effect.
We try to shorten the procedure time, stimulating only the left side for AV the innervation, right? Because you're always going to have the high response on the left side. Which parameters are you using for stimulation? Because the issue of the extracardiac vagal stimulation that is need to be available for everybody. And that's the main problem.
So we're using the generator that was built by Pachon, but I also go around other centers and I've used a lot of different stimulators. I know that the Fisher-Paykel one, so the which is used for local regional anesthesia, works very, very well. It has very, very good response. I would say that I don't use a standard like a voltage or current setting. I try to find the lowest threshold that works. And I think that the response is almost binary. I mean, if you have a very good response at baseline and you have a very significant pause, then in my opinion, the endpoint is always very clear with vagal stimulation. I mean, there's not a lot of room for ambiguity. You know if you've done a good job or not, and there's not much of a gray zone.
I will ask a question. For example, you did one ablation point in superior vena cava and then increased the heart rate and applied extracardiac vagal stimulation, and there is no sinus bradycardia. And I can do that in almost 80% of patients. Is it enough for you? You completely eliminate sinus bradycardia.
No. So this was also for the purpose of the case, but I tend to do the other way around. So I tend to start as low as possible. So meaning lower down inside the heart and move progressively upwards. Okay, because my main concern is to have axonal damage before the cell bodies. Okay, basically you have the axons going down, they get the cell bodies, and then they go towards the sinus node. So if you start lower down, you're probably damaging the cell bodies. And if you start very high, you have a high chance of damaging the axons that are coming down. This is clearly a point that's very important. And I mean, to push things, you talked about patients that had heart transplants. So patients with heart transplants, as you mentioned, they have reinnervation. That's because they had only axonal damage. I mean, when you take the donor heart, you cut at the level of the superior vena cava, so you're cutting the axons, and you're not damaging the neuronal cell bodies. So you will get eventually reinnervation. It takes a long time, and there are studies that show that reinnervation is still ongoing 5 years after the transplantation. So it really takes a long time for the axons to regrow and to find their path through the scar, but it happens. And if you damage the cell bodies themselves, I mean, this data is from the Pachon group. They show that they have very good, very long-term data. After 7 years, there's no significant reinnervation. They show, and other groups have also shown this, that after 1 year, basically most of the reinnervation that should have happened has happened, and there's a plateau after that. So, but I think this is obtained if you're really focusing on the cell bodies. And for me, this is a limitation of whatever the technique you're using. You can never be sure you've damaged the cell bodies, so you should use other like indicators to try and target them.
Yes, this
just
is
a quick comment on that. Just a quick comment.
I will ask your idea. I will ask your idea. This is why I mentioned for acute success, yes, extracardiac vagal stimulation is perfect tool. But just for acute success, we have to understand that extracardiac vagal stimulation doesn't say anything about your epicardial ganglia effect, anything. Because just ablating postganglionated fibers, you can eliminate this response, like increased heart rate. This is why, for example, some groups use right atrium only approach, some groups use left atrium only approach, some groups use biatrial approach, and acute success rate is always same. Maybe 97%. This is the reason. But once you follow this patient, you are seeing reinnervation. So to actually, for example, you did extracardiac vagal stimulation via left or right valgus, you are still seeing some AV block. The reason is not your epicardial effect. The reason you still couldn't ablate these postganglionated fibers. If you can find these postganglionated fibers are because please remember that, for example, if we are talking about sinus node, all nerve fibers travels firstly convergent and then travels to sinus node area. This is also applicable for AV node side. So if you just can find this convergence area for AV node postganglionated neural fibers, you can eliminate extracardiac vagal stimulation again without doing anything in epicardial GP area. And I think that by combining of CT scan and combination of, I don't know the best technique, but maybe fractionation, maybe peak frequency, I don't know, still don't know the best one. And then once we eliminate these fibers or these electrograms, we will be sure about real epicardial ganglia effect.
So I would argue that
there's something, Josselin, that just let me make a comment on this, because yes, we need to find the best option and the best way to ablate. We need to find a special set of lessons that we can ablate few points to have higher denervation. How are we gonna find that? I don't know yet, but this is why I'm excited about CT, because with the CT images, I can see the fat pads. And when we're mapping the electrograms inside, and we can correlate these, maybe in these correlation points, you're gonna achieve higher denervation effect. The way we have to measure that is using the extracardiac vagal stimulation as an acute result. But for personal experience, and we have published this, since 2014 that we started using the extracardiac vagal stimulation, it's hard to find recurrences. You have to redo another cases. The patients that I need to make a redo procedure was before we were using that. And maybe we ablate a lot, but not in the right sites. When we started mapping, we became more selective in these kind of ablations, getting better results on this. Trying to measure this response with extracardiac vagal stimulations helps me to ablate less once I abolish this response. That's why we try to find this. This is a way to combine information, anatomical landmarks, electrograms, CT scan, and a question that was asked is here, intracardiac echo. I'm trying to find these spots relation with anatomic landmarks and also in the intracardiac echo. And you have always the coincidence of the same points that you see the electrograms fractionated and where you ablate all with anatomic landmarks. And I see in this representation as well with the tomography right now.
Yeah, I just want to comment maybe on the on one point. Tolga, you mentioned that probably the acute effects would not be enough because of the because we're also damaging post-ganglionic fibers. And I think the argument you were trying to make is maybe we need to ablate GPs that are not only septal. Is that right, or am I deforming?
No. Just for acute effect. Because, for example, left superior GP contains too many ganglia. We know that, but maybe it is not important for cardioneural ablation. We don't know the answer, because to do that, to say anything about that, we need a comparison study. And
yeah, so what I wanted to say is that there is some data about this. So there's the study, the Chinese study, where they randomized the order of the GP ablation. You know about this study. I don't remember the other. I think it's who.
Just order, but at the end they ablated whole GP sites.
Yeah, in the end they ablated everything. But when they randomized the order, what was interesting is to see they showed where they had at least acutely an effect in terms of denervation. To assess that, they looked at the heart rate and see which GPs led to an increase of heart rate. And in this study, they showed that ablating the left superior GP really had no effect in terms of heart rate. So acutely, you didn't have a denervation when you were ablating there, even though there were, as everybody knows, when you're ablating there, you frequently have very strong vagal response and you can get pauses. Okay, but actually ablating there didn't lead to acute vagal denervation, at least of the sinus node. We can't conclude anything about the AV node because they just looked at heart rate. But I think this is a very strong argument to say that the left superior GP at least is not involved in the innervation of the sinus node. My personal experience is that sometimes it's involved in a limited number of cases. It might be involved in innervation of the AV node, but for me, clearly this points to the fact that it's not innervating the sinoatrial node. So I mean, this is also the rationale why we're just focusing on these regions, and I understand what your concern about post-ganglionic fiber damage, but I think that our good long-term results plus this data and the data by Hannah, which is more on an animal model, I think are good arguments to say that these are really regions, the main regions that are innervating the sinus node and the AV.
We completely same point for right superior GP. I'm not talking about the importance of right superior GP. We have also such a comparison study, by the way. The point is to perform ablate in posterior septal wall of superior vena cava and to see increase on heart rate or to eliminate extracardiac vagal stimulation is not to say we ablated right superior GP. Okay, this is the point, because after one RF point, you can eliminate extracardiac vagal stimulation response. Maybe after 2 points, because Philippe De Bruyne did that. It's possible. It's not too difficult, but you know, according to your CT experience, you have already demonstrated great pictures, and right superior GP is not that tiny. You cannot eliminate this GP after 2 RF points, but after 2 RF points, you can increase heart rate. This is my point. I am not talking about left-sided GPs.
Yeah.
Just to pre-avoid ablations and to see the abolishment of the extracardiac vagal response, just give you like an acute response. Remember, we are not ablating the GP, we are ablating the network. And I agree with you, we have to go bilateral ablation. You have to make a good ablation to get a good results. We are running out of time, and we're gonna
Just one question, Dr. Zerpa, for all of you.
You can make your comment too, yeah.
I've been ablating for about 30 to 40 seconds per site, and I think Dr. Duchateau mentioned a minute per site, and we want to get very deep. How about you two? How long do you ablate per site?
I go for 20 to 30 seconds. Good contacts, good impedance drops with quality ablations.
Yeah, 30.
30 seconds, okay.
When you see that in the intracardiac echo, you see that you go transmural,
Yes.
and you get this control there as well. So that's a way to see that maybe that is enough.
But I think doing
comments?
50 watts for 5 seconds, 10 seconds is not good in this case. We need longer
This is
lesions.
something that we don't know because you go shallower lessons there, and we want to go transmural. That's why we go for conventional potency.
You know, Mo, there's the work by Elad about like how deep you can go, for how long you should ablate if you want to reach your plateau. And plateau is usually, I mean, in his work, it was usually around 2 to 3 minutes of ablation. And I tend to see that if you go beyond 30 seconds and continue to 1 minute, you're still getting acceleration. So you still have some building up of the effect as you prolong your lesion. So this is why I use more, at least.
Because for VT, I stay on for a long time, sometimes for 2 minutes on the spot.
Yeah.
Well, I can see with this group, this is a lively discussion, and we could probably go on for several more topics and questions. But I did want to say overwhelmingly in the Q&A is comments around the excellent presentations. So thank you again to Dr. Sadek and Duchateau for your excellent presentations, and thank you to our guest panelists here for the excellent dialogue and for carrying on and moderating many of the questions. So it has really been a wonderful webinar, and thank you for sharing your experiences with the inHEART solution. And to our attendees, thank you for staying on well past the hour to listen to this engaging dialogue. If you do have more questions on inHEART, please reach out to sales@inheartmedical.com. Or if you'd like to watch previous webinars, which are equally engaging, although I may say this may be the most, please visit inheartmedical.com and select webinars from the main menu option. So thank you everyone for your thoughtful presentations and discussions today, and we hope you have a great day.
Thank you.
Thank you.
Thank you.